Hello everybody. We are going to be discussing chronic kidney disease. The focus of our case study is a 27-year-old male who 3 years ago presented to the emergency department with a 6-hour history of hemoptysis. He had recently recovered from a 2-week influenza A infection, and on presentation to the ED, he had an elevated white blood cell count and iron deficiency anemia. Laboratory tests showed the presence of anti-glomerular basement membrane antibodies in his blood, and renal biopsy confirmed the presence of those antibodies attached to his glomerular basement membrane. These results were used to diagnose him with Goodpasture syndrome, where the body's immune system attacks the kidneys and lungs. Initial treatment was with plasmapheresis to remove those antibodies from his blood, and treatment with corticosteroids, prednisone, to slow down the production of antibodies by his immune system. Afterwards, he was maintained on an immunosuppressant, azathioprine, and an antibiotic, sulfamethoxazole and trimethoprim, which treat opportunistic infections in this now immunocompromised state. At this time, 3 years ago, his creatinine was not elevated, although he was notified of the possibility for developing chronic kidney disease as a result of Goodpasture syndrome. The patient has had 6-month follow-ups for the last 3 years since diagnosis, and at his most recent appointment, his creatinine is now 7.14. The process of chronic kidney disease starts with an injury to the kidney. In this case, it's from these antibodies attacking the glomerulus, but it can also be due to acute kidney injury or a chronic disease like hypertension that over time damages the kidney. The injury creates a state of hyperfiltration in the remaining nephrons, as they have to do the work of the non-functional nephrons to meet the filtration needs of the body. In the short term, the remaining nephrons are able to meet these needs by doing more than their fair share of filtration. However, over time, this hyperfiltration and increased pressure in the glomerulus leads to damage and an increase in the permeability of the glomerulus that lets proteins and red blood cells through. This leads to sclerosis of the glomerulus, and the proteinuria leads to inflammation and fibrosis in the nephron, further damaging it. Over time, this continuous cycle perpetuates the hyperfiltration and dwindling of remaining nephrons as they're damaged by this increased workload. As the number of functioning nephrons decreases, the GFR decreases until the patient reaches end-stage renal disease and the remaining nephrons can no longer meet the filtration needs of the body. Now, there are many symptoms that chronic kidney disease can cause. Our patient has some of the more common ones, like itching, the peripheral edema and pulmonary edema from loss of albumin and possibly fluid overload, anemia because the kidneys make erythropoietin, azotemia, which is an abnormally high concentration of nitrogenous compounds like urea and creatinine, encephalopathy, which is impairment of the nervous system from the toxic effects of those nitrogenous compounds. In this case, the patient reported very poor memory and trouble concentrating, so much so that he could no longer work, and the Chvostek sign, which indicates hypocalcemia. As of 2013, the total number of patients with chronic kidney disease in the United States was 13%. And of the 661,000 Americans with end-stage renal disease, about 70% are on dialysis, with the remaining 30% with a functioning kidney transplant. Goodpastures is extremely rare, with estimated incidence a little more than 1 cases per million per year, and the prevalence of the disease is higher in young men and older women. Risk factors for Goodpasture syndrome are things like cigarette smoking, exposure to inhaled hydrocarbons, vascular disorders, and acute kidney injury, as well as genetic predisposition. While it is linked to influenza A infection, it's not exactly understood why. However, there are several theories. In regards to chronic kidney disease, it is well documented that over time, poorly treated diabetes and hypertension can lead to chronic kidney disease. The natural history of chronic kidney disease is variable between diagnoses with regard to the decline in GFR. And it's also variable between individuals with similar diagnoses, with some slowly progressing or never progressing towards end-stage renal disease, with others rapidly progressing towards it, especially like following an irreversible acute kidney injury that drastically reduces the number of functioning nephrons. The literature we reviewed showed a strong association between the downward trajectory of patients' GFR and care practices. Patients with more rapid decreases in GFR were much less likely to have seen an outpatient nephrologist in the 2 years prior to initiation of dialysis when compared with those with more gradual decreases in GFR. And patients with rapidly decreasing GFR were hospitalized more frequently and more likely due to an AKI than the more gradually decreasing GFR patients. Whereas acute tubule necrosis or hematologic malignancy were more associated with rapid declines in GFR, chronic diseases like diabetes or hypertension were associated with more consistent gradual decreases in GFR. Prompt and consistent treatment by a nephrologist, prevention of acute kidney injury, and continued health maintenance can help prevent or slow progression towards end-stage renal disease. Plasmapheresis is a procedure similar to dialysis, where the liquid portion of the patient's blood is replaced. This is a great way to get rid of antibodies that are attacking the body's tissues. This is a great way to treat Goodpasture syndrome, and with each treatment, 60 to 70% of the circulating antibodies are removed. As the glomerulus gets damaged, its ability to filter is compromised as it lets through larger particles. In addition to the limited number of functioning nephrons, angiotensin II also stimulates hyperfiltration by causing vasoconstriction of the efferent arteriole. This leads to chronically high intraglomerular pressure, which damages the glomerulus and leaves pores in the membrane. Not only are the pores in the filter large enough now to permit proteins and red blood cells to pass through, but the negative electrical charge of the membrane is also compromised. This charge functions to repel large negatively charged proteins like albumin, which soon are present in the filtrate in high enough concentrations that they overwhelm the nephron's ability to reabsorb them. Stages of chronic kidney disease are determined by the patient's glomerular filtration rate. This represents the kidney's capacity to filter blood. 3 years after diagnosis with Goodpasture syndrome, our patient presents with a GFR of 10 milliliters per minute, standardized for body surface area. This places the patient in stage 5 or end-stage renal disease. This is low enough that the patient requires dialysis, as the filtering capacity of the kidney is no longer enough to maintain homeostasis. We calculated the patient's creatinine clearance using the Cockcroft-Gault equation. Using the patient's age, weight, and serum creatinine, we determined his to be 17.05 milliliters per minute. This is severely reduced, as normal for a male is considered 97 to 137 milliliters per minute. Utilizing the abbreviated MDRD equation, we calculated our patient's GFR at 10 milliliters per minute, standardized for body surface area. A positive Chvostek sign is elicited by tapping over the facial nerve and eliciting a facial muscle contraction on the ipsilateral side. This indicates hypocalcemia, as lowered serum calcium places nerves in a more hyperexcitable state. In the process of treating our patient, blood tests showed an elevated white blood cell count, signifying an active immune system. An ELISA test, which is similar to a pregnancy test showing the presence of a molecule or protein in a solution, was used to detect the presence of the anti-glomerular basement membrane antibodies. Renal biopsy was used to visually confirm the presence of complement proteins and antibodies attached to the glomerular basement membrane. Lastly, urinalysis showed the presence of protein and red blood cells in the patient's urine, which are hallmarks of chronic kidney disease. The patient will require frequent dialysis, so referral to a nephrologist will be necessary to develop a plan and ensure adherence to the dialysis schedule and follow-up. The patient will continue to receive dialysis while they are evaluated for the possibility of transplantation. Diet changes like reductions in protein, sodium, potassium, and phosphorus are necessary to prevent electrolyte disturbances. He also may require referrals for cardiology and endocrinology to address his risk for cardiovascular disease as well as diabetes. Drug dosing may have to be altered due to his kidney dysfunction, and nephrotoxic meds such as NSAIDs and herbal supplements should be avoided. Should he receive a kidney transplant, he will have to take immunosuppressants for life to prevent rejection. A referral to a social worker may be warranted, as this will have a major impact on his life. He will need to identify a support system from family and friends, as well as identify any financial needs he may have that could preclude him from adhering to this plan.